Thank you very much. I'm very fortunate to have chosen pediatric orthopedics as a subspecialty. It forces me to think more long-term, and also having great mentors such as Dr. Weinstein and Dr. Mills I'm very fortunate. This is a very simple study that we did, mostly because one of our former hip fellow, Matt Boyle from New Zealand, his sister was a ballerina, and he wanted to know. His assumption was that a lot of ballerinas have hip dysplasia, and if you were to treat them with an osteotomy, how would they do? So it's a very simple study. Please take it for what it is. As you know, dancers require an extreme range of motion. There's some good studies from Geneva showing, using MR, that in the split position, they can actually subluxate their hip, and these are hips with normal morphology. And also, even in the face of normal hip morphology, a lot of these hips will have labral and chondral damage. And the question is, are these hips that are dysplastic, can that be protective? And if we were to fix the dysplasia, are we going to make things worse for them? Now, dancers have a higher rate of hip pain than normal populations. It's almost an occupational hazard for them. And it's assumed that they have increased rates of acetabular dysplasia, although when I look through the literature, that's really not been documented. Now, what would you do if you have a patient that's a dancer that comes in with the labral tear, and they actually have acetabular dysplasia at the same time? There are a few centers in the world, I think HSS is one of them, where they do see quite a few dancers, and I think the preferred treatment is to simply treat the labral tear. And I'm trying to challenge that assumption, whether or not that's the right thing. So I think we all know this. In acetabular dysplasia, there's a static overload at the acetabular rim, as well as shearing forces at the acetabular rim, which causes dynamic instability. And the assumption is that if you simply treat the labral tear without fixing the underlying mechanics, that it's going to re-tear and cause future problems. All right. So, but we also know that when you treat patients with hip dysplasia using a periacetabular osteotomy, you will restrict their motion, especially in hip flexion and sometimes in hip internal rotation. And we don't know what that's going to do with in a patient such as dancers. So Simon Stepbacher used. We've done studies using CT scans both pre-op and post-op, and he's used that data and did 3D motion analysis. And indeed, even in a carefully done periacetabular osteotomy, you will lose a certain amount of motion. All right. So this was a simple retrospective study. The our primary outcome was the rate of return to dance after periacetabular osteotomy. We also wanted to look at the effects of on hip range of motion with the osteotomy, and as well as patient-reported outcome. This was an IRB approved retrospective study. Out of a total cohort of around 1,500 PAOs performed during this time period, we were fortunate to have had collected preoperatively some information about patient activity, which included dance. And so from that, we were able to identify patients with sufficient patient information in the chart, as well as a minimum 1-year follow-up. So from the chart review, we were able to identify these demographic as well intraoperative and surgical certain complication data. We did, again from the chart, we were able to get the rates of return to their dance activity at 1 year, and we got the range of motion information data from the chart as well. So we were able to identify 44 hips and 33 females. They're all females. Their demographic data is pretty typical. I would say their BMI is perhaps on the lower range. The radiographic data pre-op was fairly typical for the dysplastic group. They had very minimal, the vast majority had very minimal radiographic evidence of osteoarthritis. Their joint space width was in the normal range. And a lot of these hips did have fairly significant acetabular dysplasia. So center edge angle of 11 is quite significant, I would say moderate dysplasia. Now the good news is that, and this was a surprise to us because my initial assumption was that none of them would be able to return to dance. But at 1 year, 63% were able to return to their dance activity. That rate did decrease a little bit as further follow-up went on, so 43% at 2 years. And when we did have the information on why they were not able to return to dance, it was true that 9 out of 13 were not able to return because of their hip. So when we looked at the range of motion information more carefully, and this is a very busy slide, but I'll go into more detail. The significant difference between pre-op and post-op is that their hip flexion did go down by a small amount, as well as their hip abduction. So the significant difference from pre-op to 1 year post-op was a small decrease in their hip flexion, as well as abduction, but there was no change from 1 year to the final follow-up. When you look at the hip outcome scores, pretty much there was uniform increase in their modified Harris hip score as well as the WHO score, which is what we would expect for significant dysplasia with minimal radiographic osteoarthritis. Their modified Harris hip score went from 65 to 88, and similarly the WHO score increased significantly. Now we're still trying to analyze this data. Obviously this is a very retrospective study. Please take the data for what it is. However, I think I would not be as pessimistic about being able to return to dance after treating the hip dysplasia in dancers. Not all, but some will be able to return. As expected, we would expect their clinical outcomes to improve. And at least at a preliminary look, it appears that the ones that were not able to return to dance are the ones that had the most restriction in motion. So perhaps in the future, and people that treat FAI talk about this fairly often, that they're tailoring their surgery for the patient's activity. Perhaps if we do combine arthroscopy with osteoplasty and PAO and try and maintain their motion as much as possible, that we'll be able to increase the ability of these hips to return to their previous activity, as well as protect their labrum from the abdominal mechanics that are present in these joints. Thank you very much.